So today we're going to talk about women and heart disease. And I decided to give this lecture interesting title, Dispelling the Myth and Finding the Truth about heart disease in women. Because I do think that there are a lot of myths about heart disease in women. And I will tell you and explain to you why. Most of people believe that heart disease in women is not as frequent as heart disease in men. More women than men have died of heart disease each year since 1984. These are statistics that are done yearly. Today we consider heart disease as #1 cause of death in women. We feel that the statistics show that 1 in 3 women dies of cardiac or vascular complications. #2 killer in women would be lung cancer. And #3 is breast cancer. But heart disease seems to be much more frequent than cancer in women. So before we talk about heart disease in women, we have to understand what we're talking about. First and most common is the myocardial infarct or a heart attack. And what is a heart attack? Heart attack, if this is a heart, we have a vessel on the left, and we see that this vessel is occluded here, and the blood does not flow beyond that occlusion. The muscle below that occlusion is darker. This is the heart muscle, and if it doesn't get blood, there is a death of the heart muscle tissue, and a secondary to that blocked artery, and that's what heart attack is all about. The heart attack can be through the whole thickness of the wall of the heart or just superficially. What causes the heart attack? The heart has coronary arteries. Those are the small vessels that leave the heart, left and right, and they are called the coronary vessels. The left vessels is the left main vessel, the left anterior vessel, and the vessel turning back on the back surface of the heart called the circumflex vessel. On the right, there is a right coronary artery. As you see, the heart muscle is thick, and the heart and these vessels are very small. What is the difference between men and women in presentation of heart attack? Women would usually present 1 hour later with symptom of infarct than men. Usually they would discard their symptoms much more than men. They just think that they're tired or there is something else going on. Women also have much smaller arteries. Those arteries that I showed you, they are much smaller and thinner. And even if you adjust by body surface, so the plaque is much more obstructive to that artery compared to men. Also, studies have shown that this plaque that I showed before will most frequently erodes in women. In men, usually it will just rupture. This is a blocked artery. The top of the picture shows normal artery with clean internal surface. And the lower one shows an artery with a plaque of cholesterol. If this plaque breaks, there will be some clot formation there. And even if this artery is only 50% closed, if there is a clot formation there, the artery will completely close and will cause a heart attack. So one of the myths that exists today is that women are protected from heart attack by hormones. Also, there is a myth that heart disease is disease of men. Also, there is a myth that there is no chest pain. If there is no chest pain, there is usually no heart attack. And that the risk factors that apply usually apply to men. The truth is that the heart disease is #1 killer in women, that women's symptoms show 1 decade probably later than in men, and that the chest pain is less frequent in women, and there are other symptoms that are more common than chest pain, and the risk factors for women and men are similar. So what is a typical chest pain that a person presents when they have a heart attack? It would be like a tightness or pressure, a heavy feeling, like something sitting on the chest. This can be with or without sweating. It can be with or without exertion, and can sometimes be precipitated by emotional stress. Atypical chest pain, which is more frequent in women, will be just a shortness of breath. Patient will tell you, I just get out of breath when I walk. If she doesn't walk, she doesn't get short of breath. Sometimes they feel just nauseousness, sometimes feel burning sensation or belly pain, neck pain, back pain, or even jaw pain. Many people that have angina, they go to a dentist first. So those are the typical symptoms of presentation. The other difference between men and women are that until now, women have had much less interventions done on their heart, which may have precipitated a higher death in women. And much less prevention has been done in women and less treatment. We have less cholesterol screening, less lipid-lowering medication in women. We use less beta blockers. Heparin, aspirin is a big problem using in women. Then the platelet therapy, so-called Plavix, it's much less used in women than men. And much less pacemaker and defibrillators are inserted in women who have already had a heart attack. And those are devices that can prevent sudden heart death. So how should we evaluate women with heart disease? We should always ask very detailed questions about their symptoms and be always very suspicious, even if they don't give you a chest pain. And the evaluation is very difficult because I said they present a decade later than men, and they have other problems, other comorbidities. They are very disabled, may not be able to walk, so the shortness of breath, they don't feel the shortness of breath because they don't walk. Also, the tests that we order can be very frequently false positive, and this is due to their inability to exercise or because the breast is throwing some shadows over the heart, and their EKG changes due to hormones or it's already abnormal. So it's very hard to decide by looking at the EKG, do they have something going on or not. One of the tests that we do very frequently is the exercise stress test. That's on the top of the slide. Exercise stress test is a test where we put the patient on a treadmill and we exercise and we look at the EKG. Well, not too many women can do that. They already have some arthritis, problem with walking. So, and the EKG should be completely normal before we order this test, because if it's abnormal, it will be a waste of time. So very frequently we do nuclear stress tests. That can be done also with exercise, or we can do a chemical nuclear stress test where people don't have to exercise. This is a picture of a nuclear stress test. This is the heart seen in 3 views, short axis views, and the heart looks like a donut in short axis views. And the top picture is picture of the heart after patient exercise or after she had some kind of chemical to look at the heart. And you can see on the top picture, the heart should be a full donut. This part of the donut is missing around 11 o'clock. And also on the back of the heart is something missing too. On the resting picture, when patient does not exercise, you can see that some of that missing area comes back, which means that the area where that defect is, probably there is a clogged artery. Also, the back of the heart has defect at rest and stress, which means that this patient already had a heart attack before. The other type of stress test is with echocardiogram. And maybe you have heard of CAT scan, the new 64 slices CAT scan, and something called calcium score, where we measure how much calcium it is in the coronary arteries. And also the gold standard to diagnose heart disease is always the heart catheterization. This slide shows you that on the left side, the artery looks normal. On the right side, the artery is 50% blocked, but the lumen still looks pretty good. But here there is erosion on this plaque, and the blood cells are already forming a clot. And if this clot starts expanding, this patient will have a heart attack. It's very frequent in women that the vessel stretches, and when you look at it, it looks normal. But there is a big plaque there that can be quite dangerous. And that lining called endothelium, this lining inside the vessel, is the lining that we care about. This lining has to be healthy. It's called endothelium. One of the studies have shown that in 400 postmenopausal women, that the blood pressure was one of the most important risk factors to keep that endothelium healthy. What about the cholesterol? All this that we saw there was a cholesterol plaque. Cholesterol plaque that then has become fibrosed. There is a cap here. If this cap breaks, that's what the heart attack, that's when the heart attack happens. And the other problem that's very important is the smoking. The smoking is #1 problem in women. I feel that it's #1 problem in women. I usually see a lot of women, and if they come in a younger age, I usually don't consider them high risk unless they tell me that they smoke or they have diabetes. If they have smoke and diabetes, I tell them that all the bets are off. Very frequently, there is so-called paradox in women. We send them for heart catheterization. They have a lot of chest pains, but when you look at them, they have clean arteries. The reason for that is frequently that the vessels in women that get disease are the small vessels. So when I talk about women and heart disease, I always think about like a tree with small branches. And the disease in women, especially diabetic women, is in those small branches where you cannot intervene. And that's why the prevention is number one. So when we think about women and heart disease, I think we need to think a little bit out of the box. We don't need to just think the same way as we think about men and heart disease. And that is because women will have more ischemia. Ischemia is like when the heart doesn't get blood. Less angina is the chest pain. They usually would not have chest pain. When you look at the heart catheterization, you will see less obstruction of the vessels. And they have a high incidence of heart attacks and higher death rate. And something called CRP level that we frequently measure in women is much higher. And that CRP usually says that there is some kind of inflammation going. And but the therapies, we don't have any different therapy for women than men. The therapy is the same. The next question is, what about hormones? There were many studies done about hormones in women, and the conclusion of all of these studies is that they are not helpful for the heart. They will increase the triglycerides, increase the clotting, increase the CRP level, which will make this endothelium, this lining of the vessel, much more susceptible to harmful stimuli. So hormone can help the treatment, the menopause symptoms, and they can be used maybe for a short amount of time, but not for primary or secondary prevention of heart disease. Women that have that take hormone therapy, you check their cholesterols, their good cholesterol is much higher, and bad cholesterol is much lower, and it looks so nice. The cholesterol profile looks very nice when you look at it, but it doesn't mean that it's protecting them. It's actually harming them. So that's why at this point, we do not suggest any hormonal therapy in women. And there is something called broken heart syndrome or octopus heart. This was like some Japanese story about octopus who fell in love. So it's not just a story. It seems there is a proven fact that people can have a heart attack-like picture from something stressful going on in their life. So there have been a lot of studies lately, and the most recent study showed in 70 women that they have had sudden weakening of their heart after some kind of grief or fear. I recently had a woman who had, her granddaughter had leukemia, and she came with the symptoms of congestive heart failure and heart attack, and we did a catheterization, and her arteries were open, but her heart was weak. So this is so-called broken heart syndrome. It's one of the rare cardiomyopathies that it's reversible. There was another study done about women and aspirin. A look at the women over 10 years period with aspirin versus placebo, and found out that there is a 24% reduction of stroke in women who use aspirin, and 22% decrease in risk of small stroke, what we call minor stroke, TIA, and that there was no significant increase in risk of hemorrhagic stroke. So shall we give aspirin to women? Compared to men, women have more strokes than men. And according to this study, our guidelines are the following. If the woman is older than 65 and we feel that she's high risk for cardiac heart event, then we should give aspirin because it will reduce heart attack 26%, and but there is some risk of bleeding in women. So in high-risk women, we should use aspirin if they're older than 64, considering that the blood pressure is well controlled. Because very frequently you can get stroke just from high blood pressure, bleeding stroke. So if the benefit of giving aspirins are bigger than the risk of stroke, than risk of bleeding, then you should give aspirin to a woman who is older than 64. If woman is younger than 64, use aspirin only if we already had some problem with the heart or had some very high suspicion. What about supplements? Vitamin E, C, B, but all the studies have shown that they have really no big role in prevention of heart disease. Also folic acid, which is part of the vitamin B group, does not help in primary or secondary prevention of heart disease. But vitamin D lately has shown to need to be used in primary prevention. And then there is something called homocysteine, which we have been checking for last few years. And this Norwid trial showed that doesn't help much in prevention of heart disease. So this new trend of us giving vitamin D to everybody, so-called sunshine vitamin, it's very important. Lowers the CRP, which is that inflammatory factor that keeps the endothelium healthy, helps the bone, helps the heart, and we feel that it does some cancer prevention. And then about the heart disease in different racial and ethnic group of women. Apparently African American women are the highest risk of death from heart disease among all racial and ethnic and gender groups. And they followed by Latinos, Asian American, Pacific Islanders, and American Indians. This is another study about women and heart disease, a use of estrogen and progesterone, and again shows that these hormones do not help with the heart. These people that took the hormones had excessive number of heart attacks and strokes, also pulmonary emboli, clots in their legs, and increase in breast cancer. The only benefits of the hormone therapy seem to be fewer hip fracture and fewer number of colorectal cancer. This is the same graph that shows those numbers. So how do we approach the women when we evaluate them for heart disease? We try to assess what kind of risk they have. We usually ask family history, smoking, and from that story that they give us, we try to put them in certain group, what risk group they belong to. Then we try to do some lifestyle changes and treat other diseases like hypertension, diabetes, cholesterol. Then we look into certain intervention and try to avoid therapies that have not been helpful, like supplements that have not been shown to help. If patient already had atherosclerosis, which means already had a heart attack, if they had a bypass on the legs, if they had stroke, if they had aneurysm. In the Framingham study, people that had a kidney problem, they had increased risk of heart disease, more than 20%. And this is how embolic stroke looks. Embolic stroke is some clot from the heart or some other vessels goes in the brain and damages the brain. Just like that vessel damaged the heart, in this case, will damage the brain. And this is how peripheral vascular disease is. Same risk factors that cause heart attack can cause the disease of the arteries going to the legs and to the arms. Usually people that have one problem would have that problem probably also. This is most common, the peripheral vascular disease in smoker. And the main symptom that we ask for when we ask about this disease is how long can you walk? If you cannot walk more than few blocks and you have some pain in your calf, that means maybe you have developed some peripheral vascular disease, and that symptom is called claudication. This is a different kind of stroke. This is not a stroke that's caused by clot in the brain that came from the heart or somewhere else. This is ischemic stroke. The vessel of the brain are as narrowed as the vessel in the heart. So how will we define metabolic syndrome in women? We said that metabolic syndrome was one of the risk factors for heart disease. Women who had, mostly people who have the metabolic syndrome, have obesity in the area of the waist more than 35 inches. Their triglycerides are higher than 150. their good cholesterol, the HDL is the good cholesterol, is too low, it's less than 50. Everything that's good is protective to the heart, so good cholesterol should be much higher. The blood pressure is 130/80 or higher, and the fasting glucose is more than 100, which means they are probably borderline diabetics. We always have to intervene with this kind of people. Insist on smoking cessation, physical activity, heart-healthy diet, and weight reduction. You can see here a comparison of people that smoked and people that not smoke. You can see that there is a major difference in people that smoke and didn't smoke and their heart attack risk. So we always have to ask about smoking, insist that they stop smoking, advise how to do it, assess if they're willing to stop smoking, and always arrange follow-up with them to ask them, did you stop smoking or not smoking, and help them any way we can. Exercise in women, a great effect on prevention of heart disease. This is a graph where it shows more you walk, better prevention. Sedentary lifestyle is something that we should truly avoid. 40% of women report no leisure or time or no time for physical activity. So we should always encourage women to walk at least 30 minutes a day of moderate intensity walking, preferably every day, 30 minutes. If a woman wants to lose weight or sustain the weight loss she has already done, then 60 to 90 minutes of walking a day, every day if possible. The diet, I saw you have a dietitian here, is very important. Saturated fats, less calories, and limited trans fatty intake. Blood pressure intervention is also very important. Target blood pressure for women should be less than 120/80. The blood pressure medication has to be maintained. Blood pressure has to be maintained in a lower range, below 120, in order to benefit. And cholesterol has to stay within the guidelines. And if you're diabetic, your hemoglobin A1C has to be less than 7 in order to prevent heart disease. So we said we use the same medication for women and men. The medication are usually diuretics for blood pressure, beta blockers, and ACE inhibitors and angiotensin II blockers. This is a slide which shows that the coronary disease mortality in diabetic women is much higher than in regular women. So control of diabetes is very important. Among women who are married and cohabited with a male partner, marital stress was associated with 3 times increase in risk of heart disease. So living alone and work stress did not significantly increase recurrent heart disease events. I always thought that work is good. So what do? Number 1 is prevention and risk control, everything that I have talked about. And when prevention and risk control fails, then there are other things we can do. Angioplasty and stent. This is what the angioplasty and stent means. This is angioplasty. When we put with a catheter that goes into the artery and comes inside the heart, we put you see the plaque here, and there is a wire passing the plaque and then pulling back. The balloon inflates, breaks the plaque, and push it on the side so that a vessel remains open. This used to be the first procedure we used to do, angioplasty, to break the plaque. But right now, this is done only as a part of putting stent. So when people have stent, first they do angioplasty, spread the plaque, and then they pull that catheter and they put another catheter on another balloon, and on the balloon there is a stent. This mesh, the balloon comes out, the mesh stays in, and keeps the plaque pushed away and keep the vessel open. After stenting, people have to be on some kind of blood thinners, Plavix, to keep the blood from seeing the stent and clotting the stent. So it's very important to keep with the medication after a procedure like that. And if there are too many vessels, too many blockages in the heart, then we do surgery. And this is a picture of what's done when people have bypass surgery. The one on the left is the vessel, the so-called mammary artery. It's taken from the wall under the ribs, and it's attached to the heart. The other grafts are a piece of vein taken from the leg, attached to the aorta, and then attached below the blockage. After you have something like this, it's not guaranteed for life. You see what happened to Clinton. He had to go and have a stent again. because cholesterol blocked some of these grafts. So even after this kind of procedure, we always have to do the same as before, prevention and control. Cardiac rehab is very important after something like this, or even for primary prevention. Women go much less to cardiac rehab than men. We have a good cardiac rehab program in Kingston, where they teach, they exercise, feel much more comfortable exercising, and they are taught about diet and to recognize their symptoms. Cholesterol is as important after bypass surgery as before the surgery, to prevent occlusion of these grafts and further occlusion of their native vessels, because you cannot bypass everything. If you remember the tree, it had so many branches. You can put 3 maybe bypass, but what about the other branches? So you have to keep diet and exercise and cholesterol control. In very high-risk women, we feel that the LDL, the bad cholesterol, has to be less than 100. In these people that have had bypass surgery, even if their cholesterol is closer to 100, we still want to put them on statin therapy because that will prevent further occlusion. These women would have more than 20% 10-year risk for heart disease, for heart attacks again. After heart attack, we always use aspirin. Aspirin is the main drug after any kind of intervention. On top of that, we use Plavix also. If there is too much bleeding, bruising, we try to keep the aspirin to baby dose. Beta blockers should be used indefinitely in all women who have had heart attacks. And they help with the heartbeat, help recover the heart function, prevent arrhythmias. Then so-called angiotensin II blockers or ACE inhibitors, they should help to recover some of the muscle function in people who have had heart attack. So in conclusion, gender differences exist both in diagnosis, treatment, and prognosis of heart disease in women. And knowing those gender differences is very important in appropriately treating women with heart disease. And in doing that, we use evidence-based guidelines that are guidelines provided to us from all the studies that they have done on women lately. So our goal is a strong heart. Thank you. Do you have any questions?
When you say that aspirin shouldn't be used as a preventative, are you talking about
Women.
Yeah.
Women, because they have a high risk of bleeding.
But even baby aspirin?
We should use aspirin unless we believe that the patient has high risk of stomach bleeding. Very frequently, people bleed from stomach or nose, or and if you give them aspirin, you can provoke more bleeding. So we usually suggest that patient has enteric-coated aspirin. But if you have a chest pain, sudden onset of chest pain, what we suggest that people go have some regular aspirin at home. So the first intervention when you have a chest pain or something is go and take 4 regular baby aspirins, not coated aspirins, but regular baby aspirins. That's number 1 treatment for heart attack.
Q10 and fish oil are they beneficial?
Yes, fish oil is beneficial to lower triglycerides. So if your triglycerides are high, so when we talk about cholesterol, we talk about good cholesterol. That's the HDL cholesterol, which should be as high as possible. In women especially, it should be more than 50. If it is less than 50, it's that woman is in risk for heart disease. Once a woman becomes menopausal, the HDL, the good cholesterol drops, and in 10 years after that, woman becomes very susceptible to heart disease. The HDL can be a little bit influenced maybe by fish oil, but not significantly. The good cholesterol mainly will get higher if you don't smoke and you exercise.
What about flaxseed oil?
Flaxseed oil is a little bit different. Flaxseed oil, you have to take it, like grind it, or otherwise it has no effect. It can lower the triglycerides and the cholesterol a little bit, but it's not going to be like a statin.
Could you please explain what tachycardia is?
Tachycardia is problem of electricity in the heart. It's electrical problem of the heart. In the heart, we have a pacemaker in the heart, our natural pacemaker, that gives like electrical stimulus to the heart and makes the heart beat. Tachycardia is when some of those electrical fibers start, the impulses go too fast, okay? The tachycardia usually is a problem of conduction of electricity in the heart, not of blockage. But if patient had a heart attack and has a big scar in the heart, that area of scarring can cause a lot of rhythm problems and can cause certain type of tachycardias, ventricular tachycardias, which can be deadly. And that's usually when we give people defibrillators. But usually tachycardia like supraventricular tachycardia or atrial fibrillation, they're a problem of rhythm. They are not problem that cause heart attack.
Is there any way to prevent an attack?
Of tachycardia? Yes. There are medications, anti-tachycardia medications that can be used to prevent tachycardia, to suppress that electrical firing in the heart.
I was under the impression when a stent went in and it spread it open, that was to keep it open. What happens to that plaque? That plaque stays there also?
We don't suction the plaque out.
But then it's a higher risk for women that have had stents than men because we have thinner blood vessels?
The women have much smaller blood vessel, and the heart, so when you look at the picture of the heart is much smaller. So when we do all these tests, if you have a smaller heart and you're looking for a defect, that defect will be much smaller than bigger heart. So it's a little bit more difficult to detect. And the vessels are much smaller.
And that plaque is not going to put more
The
pressure
plaque is
on the
not
blood
gone.
vessel?
Yes, the vessel, so-called positive remodeling. You see that picture that I show you, where the vessel kind of starts stretching. No, it's not suction out. It's still there. And it can grow beyond the edges of the stent. It can grow beyond the edges of the stent.
Maybe I missed it, but family history?
Family history is very important. If the mother had a heart disease when she was younger than 60 and she didn't smoke and she wasn't diabetic, that's pretty strong family history.